right, well, welcome everybody to our afternoon session. I'm very excited about this. I was just saying to Josee that I'm very pleased to be moderating the session because it's one I very much wanted to attend. I'm just going to make a few housekeeping points. I'm just reminding people that there will be time for questions and discussions in the last quarter of the talk, and so please put your questions into the Q&A box as they come up, and I will attempt to get at all of them by the end of the session. If you need any help, I think it's in the lower left. I will paste the link to the evaluation into the chat near the end, but there's also a link to the evaluation in the agenda, in the little box in the agenda. And so welcome to Pharmacological Management of Benzodiazepine Maintenance, benzodiazepine dependence. Our speaker is Josee Lynch. Dr. Lynch received her MD from McGill University and completed residency training in psychiatry at the University of Toronto. She graduated from the Yale University Addiction Psychiatry Fellowship in 2016 and subsequently returned to the University of Toronto, where she's now on faculty as an assistant professor in the Department of Psychiatry. Her clinical and research interests include improving outcomes for patients with alcohol-associated liver disease requiring liver transplantation, development of novel postgraduate addiction curricula, and improving access to treatment for patients with substance use disorder. Dr. Lynch provides clinical care at UHN's Ajamira Transplant Center, as well as at the Rapid Access Addiction Medicine Clinic. Hey, Josee, hand it to you.
Thank you so much for the introduction, Lori, and thank you so much to all 71 participants who have joined so far. I'm just thrilled and admittedly a little bit surprised because it is Friday afternoon, and I thought, this is a tough time slot to present in, but it's wonderful to see how many joined us today. So thank you. My pledge to you is that I will do my best to make this lively. I will make this practical. And I've also left a lot of time at the end for questions, for discussion. I think this topic is one where there isn't a lot of literature, a lot of guidelines. And I think through kind of sharing how we all practice is how we learn, as is the case in a lot of addiction medicine. So I look forward to making this interactive. So firstly, let me see if I seem to have lost control of my slides. No, I'm back on. So I don't have any disclosures. As I've been asked to talk about benzodiazepines, which I'm sure is something that we all interact with on a regular basis in the patients we provide care to. I work in a rapid access addiction medicine clinic, as many of you probably do, and this is something that we treat often. And so I want to draw on that experience and on what we do in our clinic and to share some practical tips with you today. So my learning objectives are number one, I think it's always good to review some background because it's easy to forget. And so I will do that for you today, just going over some symptoms of benzo withdrawal, some of the pharmacology of it. A lot of it will not be new to many of you, but I will go through it quickly. And then we'll talk about the three main indications for tapering people off of their benzodiazepines. And thirdly, and this is the very practical part, I would like to together walk through a set of strategies to develop a systematic, safe, and well-tolerated approach to taper off of benzos. So firstly, I always like to anchor these talks with a clinical scenario because this is where this theory comes to life. And I wanted to start with it so that you think about this case as I present the rest of the information to see how it applies. And I purposefully chose a more complex case because many of you have a lot of experience with this. So this is one where there's a lot of kind of challenges that may have arisen along the way. And I just want to share with you how we treated this person in the context of our RAM clinic. So the case is of a 50-year-old man with sedative use disorder or benzodiazepine use disorder. He had been using diazepam and lorazepam for a number of years. 30 years to be exact. So it's a long time, several decades, for about 50 to 100 milligrams of diazepam equivalent per day. And when he came to us at the RAM clinic, he had had his last benzodiazepine use 5 days before presentation. And what prompted him to seek care is that he recently had to be admitted to hospital for surgical reasons. And when he was there and he needed to stay for over a week, it was a real challenge for him to have access to the benzodiazepines he needed not to go into withdrawal. There's a lot of negotiation with the admitting service. It was very stressful for him. And he recognized that, this motivated him to look into it and to try and do things differently and to taper off. So he came to us fairly motivated, wanting to taper down on his benzodiazepines. And there's also comorbid substance use disorders, as is often the case. So he had a stimulant use disorder, cocaine, which was still fairly active, uh, remote history of an opioid use disorder. Although this wasn't sustained remission, he wasn't on any opioid substitution treatment and hadn't used opioids, I think, in over a decade. So that was stable. We did a urine toxicology when he presented. It was positive for cocaine as well as benzos. We did a CWA, 15 at the time, and I remind you, this was 5 days after he had last taken diazepam. And there was also complexity in terms of past mental health history. This is someone who had had significant trauma as well as substance-induced psychosis. Though, to be fair, at the time of presentation, we weren't sure if this was substance-induced. He was very paranoid. It didn't become clear that cocaine was causing it until later into our treatment relationship. So keep him in mind as I go through the rest of the presentation. We'll come back to him near the end. So a quick Pharmacology 101 refresher. So benzodiazepines are a class of medications that all interact at the GABA A receptor in the brain, which is part of the major inhibitory neurotransmitter system in the brain. So they do that by binding to a specific benzodiazepine location, which changes the configuration of the receptor and allows chloride ions to flow through. And what happens is that you hyperpolarize the membrane, so you enhance GABAergic activity. So that clinically manifests in 5 different effects. So firstly, they're sedatives. So people take these for insomnia, to help them sleep. They're anxiolytic, they are muscle relaxants, they are anticonvulsants, and we use them also in that respect to treat alcohol withdrawal. And they're also amnestics, and they're used both preoperatively and perioperatively for that reason. So, and all benzos act in the exact same way. And the difference between benzodiazepines is based on pharmacokinetic differences, not pharmacodynamics. So how they are processed by the body is what is different, not how they actually act on the receptors. So pharmacokinetic wise, they're readily bioavailable, they're lipophilic, they cross the blood-brain barrier quite readily. I think the metabolism piece I mentioned because it comes up often, that they're metabolized by the liver by 2 different phases. Phase 1 is oxidation, phase 2 conjugation, and this is clinically important because for our patient population with either liver disease or people who are more elderly, the oxidative metabolism of the liver becomes impaired. So then if you're going to choose a benzodiazepine, it's best to choose one that relies primarily on conjugation for metabolism so that you avoid building up in the system. And so higher risk of adverse events like confusion, cognitive side effects, falls, drowsiness. So the LOT acronym, so LOT, lorazepam, oxazepam, temazepam, lists the benzodiazepines that are safer to use because of those reasons in patients with liver disease or elderly patients. This comes up fairly often in the context of alcohol withdrawal treatment. And with enough benzodiazepines over a long enough period of time, the brain develops tolerance to it. And that's because of pharmacodynamic changes, the number of receptors downregulates, and then what happens is that the person needs to take more to have the same effect. And the tolerance develops to sedative effects more quickly and more so than to anxiolytic effects. So the different effects are affected by tolerance differently. And this is the piece that leads to what we worry most about in the context of addiction medicine is benzodiazepine abstinence syndrome, which can be very uncomfortable. And it lies on a broad range at one end from anxiety and insomnia all the way to seizures and psychosis. And it can potentially be lethal. So it's something that we do have to think about and to treat. And whether somebody will develop benzodiazepine withdrawal is determined by three main factors. The most important one is the duration of treatment or duration of benzo exposure. The longer somebody has been taking benzodiazepines regularly, the more likely they are to have developed tolerance and then developed withdrawal upon cessation of them. 1 year is a marker. Like most people above 1 year of regular use will develop some sort of withdrawal symptoms. The dose is also important. So the higher the dose, the more likely withdrawal will occur. And the half-life, so shorter half-life agents like alprazolam or Xanax, which is notorious for this, is more likely to cause a withdrawal syndrome. So, and it can occur very quickly in some unfortunate people. So, after 4 weeks of daily use and after 10 days of using them for sleep, you can already get rebound insomnia. So, this happens fairly quick. And a small percentage of people will experience protracted withdrawal. And I'll show you on a slide what I mean by that. But it's withdrawal symptoms that last beyond the expected couple of weeks. So this is briefly, I won't list them all for you. This is the DSM criteria for benzo withdrawal. And I put the slide up here just to highlight the fact that it's identical to the symptoms of alcohol withdrawal. And although the symptoms are a perfect overlap, one thing that is not a perfect overlap at all is the timeline of how these symptoms manifest. So this here is a fairly common slide that I think illustrates really nicely how unpredictable benzodiazepine withdrawal can be in terms of timeline. If you look at the chart, so on the y-axis, you have the severity and signs of benzodiazepine withdrawal symptoms. On the x-axis, it shows the number of days since the last benzodiazepine was used. And there's two curves essentially. So the one to the left is what one might expect in terms of symptom progression for somebody who's been using short half-life benzodiazepines. So you get onset of withdrawal symptoms within a couple of days. The duration could be 2 to 4 weeks, longer in some cases, but generally most people fall in that area under the curve. On the right-hand side of the graph, you have the longer half-life benzodiazepine withdrawal curve, things like clonazepam, diazepam even. And if you look, the symptoms start to build up 2 to 7 days, if not a little bit later. If you remember the case I presented, he was at day 5 of not having consumed benzodiazepines. So he was starting to show some symptoms. So thinking about the timeline of things and knowing what this curve looks like, we know that he wasn't out of the withdrawal window, but rather he was probably starting to ramp up. Most of the benzos he used was diazepam. So moving forward, one thing I wanted to draw attention to as well is that when you're assessing for benzodiazepine withdrawal, it can be challenging to differentiate between symptoms of anxiety that may be because of an underlying anxiety disorder that is being unmasked by now the absence of benzodiazepines versus symptoms specific to benzodiazepine withdrawal. And the ones that tend to be more related to benzo withdrawal are the more kind of neurological feeling symptoms. So tinnitus is a common one, perceptual disturbances, myoclonic jerks. So those types of symptoms are more suggestive of a benzodiazepine withdrawal, but it can be very difficult to tell apart. So that was the pharmacology quick refresher. And I'd like to move now to talking about how, when somebody has developed a physical dependence on benzodiazepines, what strategies can you employ to help taper off? So firstly, we'll talk about the three main indications for tapering. The first one are patients that probably we don't see that often. This is more kind of in the family physician's office setting, people who are on benzodiazepines for a variety of reasons, who are taking them at therapeutic doses, but there's a lack of clinical efficacy. So they're not doing what they're supposed to do, or there's the emergence of unacceptable side effects. So it's hard to find a good reason for people to be on long-term benzos in the first place. So the recommendations tend to be anyone who's been on them for longer than 4 weeks should be given a trial at tapering down. Those patients would fall under this category. The next group of people are those on super-therapeutic doses. With super-therapeutic dose come higher risk of adverse events, so that's why it's important to talk about tapering. And then lastly, which is probably more the people we work with, is those with benzodiazepine use disorders and or comorbid substance use disorders that make benzo use higher risk. So in terms of strategies, so for the first group, and this applies to the other two groups as well, I think preparation is key. And it's so important to make the process collaborative when you're envisioning tapering somebody off of their medications. It can be very anxiogenic. Some of these patients have been on these medications for a long time. They may feel like they're not able to cope without them. They may catastrophize what life will be like without their benzodiazepines. So it's important to give the time to allow them to speak about these concerns and to process them together and to plan for them as well. And sometimes having an appointment just to talk about the preparation piece can end up buying a lot of time in terms of buy-in that will make the next steps go more smoothly. Involving them in planning the tapering schedule is also important. Getting them to choose as much as possible how they want to see things progress when you're talking about reducing and potentially stopping the benzodiazepines. Don't plan it around a time of high stress. Granted, many of the patients we work with are in fairly perpetual crisis, are struggling with a lot of difficulties in their lives. So it might be hard to find a good time, but as much as possible, trying to choose a time that works best for them is important. Educating the patient a lot about the difference between some rebound anxiety and insomnia or some mild withdrawal symptoms from the benzos versus recurrence of initial symptoms. So it's fair to expect that there will be some discomfort, some anxiety, some insomnia, and if it gets better as the person gets used to the lower dose of benzos, that's probably withdrawal. Versus if somebody has an underlying anxiety disorder and those symptoms start getting worse and worse, then that warrants a different approach. So it's important to talk to the patient about rating these symptoms, maybe keeping a journal so that you have a better sense of the progression of things. And then plan for additional psychosocial support. It's a great time to introduce alternative coping skills, a pharmacotherapy for other comorbid mental illnesses like anxiety and depression, which are often comorbid, would be very good to ready the field, if you will, to do the benzo taper. So general tapering tips. So now this is more kind of the logistical nitty gritty. Typically for somebody on a therapeutic dose without use disorder, you can go faster, go down by 10 to 25% of the total daily dose. You observe for withdrawal, and then you just keep going. And you can keep going at that rate, 10 to 25% of the total daily dose every 1 to 2 weeks until you reach about a diazepam 5 milligram equivalent or lorazepam 1 milligram, let's say. The tail end of the taper is always the most difficult, both physically and psychologically. So it's normal and expected to have to slow down. And you can warn the patient of that so that it's not unexpected for them either. For people who've been on benzodiazepines for longer than a year, I would slow that down even more. The rate of decrease shouldn't be more than 10% per week or 5 milligram diazepam equivalent, and pick the smallest of those two. And scheduled dosing as opposed to PRN is advisable. It's easier to keep good monitoring of how many benzodiazepines they need. It's easier to keep track of prescriptions. It also has a more kind of predictable course, which psychologically I think is better for the patient as well. And typically once you figure out the schedule, so let's say you do a TID 3 times a day approach, reducing the dose and not the frequency tends to work better. So you chip away at each of the doses, and usually I let the patient choose which one they want to decrease next, depending on which time of day is most problematic for them. And then you kind of move ahead in that way. Pause the taper if needed. We have to do that often because life happens. There's unexpected things that patients have to cope with, or they don't feel quite ready, and that's okay. As long as the general trend is in the right direction, that is totally fine. Usually using the same benzodiazepine that they're used to is adequate. In this patient group, and only dispense enough to last until the next appointment. And this does wonders in terms of reducing no-show rates and also helps keep a more kind of structured monitoring schedule in place. So that is for the more kind of standard benzo taper. So now moving on to people on super-therapeutic doses. So there's a greater risk of severe withdrawal there, including seizures, psychosis, and delirium. And it can be done on an outpatient basis. It used to be that it was recommended that patients go to an inpatient monitored setting to do these tapers, but in the real world, that resource is rarely available. There are very few monitored inpatient beds where we can do tapering of different substances. So a lot of these are done in the setting of RAM clinics or outpatient setting. I think having a strong therapeutic alliance is very important, frequent contact, and also very slow taper. Although you have longer to go because you're starting from a higher dose in terms of taper, you should go even more slowly because the level of physical dependence will be greater because of the dose. And typically in patients on higher, like super therapeutic doses, switching to diazepam or a longer acting agent tends to make things go more smoothly. Diazepam is my favorite one to use for many reasons. You can reduce the dose by tiny amounts. It's very easy to control how much you're giving. It also has an active metabolite, which further smoothens the withdrawal, and it's readily available in most pharmacies too. And this is where you can consider an anticonvulsant as well, as I'll speak about a couple of more specific ones later on, but as an add-on kind of protective agent against things like seizures or other withdrawal symptoms and anxiety. So what is a super therapeutic dose? Essentially, it's just a dose above what is the maximum recommended daily dose. This is just a list of all the most common benzodiazepines and their max recommended dose from Lexicomp. Sometimes in speaking about benzo substitutions, so let's say you're starting with lorazepam or alprazolam and you want to switch over to diazepam, the recommendations have been to switch to about half of the original dose of in the original benzo, and that's to account for incomplete cross tolerance. It's the same kind of theory as for opioids that is done as well. I find that practically that's difficult to do with benzos, and usually 50% of the dose of what they used to take is not enough. So we tend to go closer to 75% and then see very frequently, very closely thereafter. But essentially, you should start your taper at a dose where the person is comfortable, and then you start tapering down from there. So you don't want to start off kind of chasing withdrawal symptoms. You want to make sure that you start from a position where the patient feels confident to move forward. So this is a quickly benzo equivalency table, just in terms of comparing the different potencies. So lorazepam 1 milligram is equal to diazepam about 5 to 10. There's a fair amount of individual variability there, but this is kind of what should be used as to guide the benzo substitution. And I spoke about adding an anticonvulsant medication. One that I often use is gabapentin. It's fairly commonly used in RAM clinics for alcohol and other things. It can be dosed 3 times a day, which is helpful in terms of the patients tend to like having something multiple times. It can help with insomnia, with anxiety. So for people on super therapeutic doses or those with a lot of concerns about not being able to sleep at night, gabapentin is often used. Trazodone is another helpful one. Mirtazapine as well, if there's a component of anxiety as well in the evening. There's some literature on things like carbamazepine, valproic acid, Topamax. I find those more challenging. It's a slower taper. They're less well tolerated. You have, pregnancy risk considerations that are more important there. And also, for example, with clonidine, you have to worry about blood pressure. So typically gabapentin is one that is a go-to, at least in our clinic. And I would love to hear from your experience. Please do share what you found helpful in terms of adjunct medications. So finally, the last group, patients with benzodiazepine use disorder and or comorbid substance use disorders. That's the greatest risk of severe withdrawal symptoms and also the greatest risk of overdose, right? I think especially for patients with opioid use disorders, there's a real risk there in terms of opioids and benzos or even alcohol and benzos. So you have to thread very carefully. There's a greater risk of diversion as well. And usually in the past has required a medically supervised setting. But as I mentioned, that's not always readily available. That's also often not acceptable to patients. They don't want to go somewhere away from their homes for a set period of time. So sometimes you have to be creative and to find ways to do this safely in an outpatient setting. In the inpatient setting, if that is available to you, wonderful. I just wanted to quickly mention that there's no validated benzo specific protocols that I'm aware of, but the places where I've worked, SIWA has been typically used, and that it's the same kind of approach of figuring out what the daily requirement is by both patient report as well as SIWA score, and then you plan a tapering protocol from that established daily dose. This can be difficult to determine from just patient report as well, because often when they're obtaining benzodiazepines from uncontrolled sources, you don't really know what they're taking. So you need to have a trial and error kind of approach to get them comfortable and then take it from there. So for the outpatient setting, however, I think what we do in our clinic is that we borrow a lot of the approaches that we use for opioid substitution therapy. So the structured prescribing that is used for methadone and for Suboxone, we just transfer that over to doing a benzo taper. For example, short prescriptions without repeats, involving the pharmacy. We've had a lot of patients do benzo tapers with daily dosing when we were concerned about their ability to take their medications safely, or for people who don't have a lot of social supports or people to check in on them. Observed dosing can be done at the pharmacy too. It's not just methadone. If you build relationships with the pharmacists around you, so many are willing to help with this. Frequent appointments, as I've mentioned, no early refills, and really having a single prescriber. I think with Connecting Ontario, it can be easier to see the different prescribed sources of benzos. I know in our clinic, whenever there's, for example, a family doctor who's prescribing benzodiazepines, we always touch base at the beginning to let them know that we're doing a benzo taper and to decide that there will be one person prescribing benzos moving forward. And then there's some monitoring options. So urine drug screens. In our clinic, we use point of care immunoassay, urine toxicology. You can't tell different benzos apart from this method, which is one limitation. But it's more for determining if there's other substance use. Also, if you send for chromatography, you can get a sense of which other benzos are being used, but that's not available everywhere, and I recognize that. We'll talk about some of the newer benzos later, and that's one place where chromatography can be helpful because those don't even show up on our regular point of care testing. Pill counts is another option, although I rarely do that because by the time the person comes to see me, they should be out of their medications, and then also checking Connecting Ontario. So back to our patient, and we'll go through this case example. I'll tell you what we ended up doing, and then I'd like to speak to you a little bit about benzodiazepines as contaminants of other drugs. And then after that, that will be it for my presentation. I look forward to your questions. But to loop back around to the case example, so just a reminder, 50-year-old man, long-term benzo use disorder. He's on day 5 of no benzodiazepines. Comorbid stimulant use disorder was in early remission, although he was still using here and there. Um, He's positive for cocaine and benzodiazepines. And also one thing that has helped with him is, I should mention, at near the beginning of starting the taper, he was on board with going to a residential facility to focus on the cocaine use disorder. And so he went there for 1 month, and this provided some environmental stability for him. And they had staff on site who spoke to us and were willing to dispense the benzodiazepines daily. So that was, I think, a good um, kind of anchor to start the benzo taper with. So what did we do? So the benzo that we used for his taper is we stuck with diazepam. He was familiar with it. It was long acting, and it was something that we could dose a few times a day in a way that was acceptable for him. We initially started, we had the luxury of having him been admitted to hospital for a surgery a few weeks before he came to see us. And at that time, they were giving him 50 milligrams of diazepam per day. That was the dose they landed on in treating his withdrawal when he was an inpatient. So we knew that that dose was enough to ward off any withdrawal symptoms. So that's where we started with him. So, and he elected to have it 10 milligrams twice a day and then 30 milligrams at bedtime. He was most worried about the bedtime dose because of insomnia concerns. So in terms of the rate of decrease, what we did is we went super slow. So 2 milligram per week from 50 milligrams total daily dose to 30 milligram total daily dose. And we did that by reducing one of the 3 dosings one at a time. And then after that, from 30 milligram to 18, we slowed it down further to 2 milligrams every 2 weeks. So we gave him a bit more time in between dose decreases to get used to the new dose. And after that, we slowed down even more to 1 milligram decrease every 2 weeks. And that was successful between 18 milligrams to 0. And I don't think we ever had to pause throughout this whole process. It went pretty steadily down, I think because we went very slowly. In terms of dispensing, we did daily dispense at the beginning for the first 2 months because there was the cocaine use on top of it. He was living in a rooming house, but didn't have a lot of great supports around. And also the duration and the of his benzodiazepine misuse. Just wanted us we wanted to be more careful. So daily dispense at the pharmacy, and he was okay with that. And then after the 3rd month, he had weekend carries, and after that, he would have every 2-day dispensing, which is what he wanted. It worked for his schedule. And then after that, weekly dispensing afterwards. And that's around when the pandemic started. And also we wanted to limit how much he had to go outside and to go to the pharmacy. We were doing urine drug screens throughout as well. Our RAM clinic stayed open throughout the pandemic, and we would prioritize in-person appointments for him. So he was able to give regular urine toxicology. So this was done through the RAM clinic, and it took 58 weeks, which seems like a really long time, but if you compare that to how many years he had been using benzodiazepines recreationally for, it pales in comparison. And I think that those 58 weeks also represented a lot of opportunity in engaging him in treatment for other comorbid conditions, which was quite lovely, actually. We saw him every 1 to 2 weeks, depending on anxiety. Anxiety was the main difficulty he had throughout the taper. And so we did use gabapentin for him mostly at bedtime, about 900 milligrams. And from getting used to meeting with healthcare providers regularly, he became more engaged. He eventually agreed to seek treatment for anxiety and trauma. Also, he started talking about how gambling was an issue for him, and he engaged in therapy for that as well. So it felt really nice to have this wraparound care and to have the opportunity through the frequent visits to connect him with more supports. Also, his substance-induced psychosis cleared completely. It turned out to be secondary to the cocaine. In terms of monitoring, we also did urine toxicology. We were checking Connecting Ontario to make sure there weren't other benzos being prescribed, and we were in touch with his family doctor. So I think that's it for this case summary. Yes. So that summarizes in one slide the process of a benzotaper in somebody with significant substance use disorder and a long duration of benzodiazepine use. And it was all done as an outpatient, which was nice for the patient as well. So the last thing I wanted to mention, and this is something that there isn't a ton of information out there about, and I'm super curious to hear from you what your approaches have been, as the issue of having benzodiazepines as contaminants of many substances, mostly opioids. So the screenshot that I'm showing right now is from the Toronto Drug Checking Service, which is, for those of you who are not familiar with it, there's a through CDPE, there's a service in Toronto that has people bring in samples of the drugs that they use and to test them to let them know what is in them. And that it's a harm reduction approach to have people be more aware of what they're consuming. And it's very shocking what is in these substances, and they keep track of it. So the screenshot I have there is from August 13th until 26th of this year, which was the most recent period available when at the time I was preparing these slides. And these samples I'm showing here are those thought to be fentanyl. So out of those, I think 82% actually contained fentanyl, and these are the other substances found. So if you look along the left side there's a few drug names that end with am, so bromazolam, flualprazolam, flubromazolam, a quite significant, like 20% bromazolam. These are all novel benzodiazepines that are contaminating the drug supply. And if you have someone who's using fentanyl often enough, it's possible that they become physically dependent on benzodiazepines inadvertently through their fentanyl use because these are so prevalent. But the issue with these is that we don't know a lot about them. They are not approved for use. These are not medications that can be prescribed. There's been very little study about them. I tried to do a deep dive into the literature. It was very unsatisfactory. I looked up the ones that were found in this sample. So bromazolam is a brominated version of alprazolam. Also, flualprazolam is actually the main ingredient in Xanax bars that people often talk about. Most often there's no Xanax in Xanax bars. It's one of these novel psychoactive substances. And it's challenging, right? Because these are very toxic things that patients take that they don't know that they're taking. And also can lead to overdoses and also benzodiazepine dependence. So it has been an issue in the context of treating patients with opioid use disorder, as some will experience benzo withdrawal as they reduce or stop their fentanyl use. So as a treatment provider, what do you do with that? How do you balance the risk of co-prescribing benzodiazepines and opioids, which increases the risk of overdose, with the risk of having your patient experience benzo withdrawal or of being so uncomfortable that they just drop out of treatment and return to fentanyl use. So it's being stuck between a rock and multiple hard places. It's really hard to know what to do. Further complicating the issue is that these new novel benzos don't show up on the urine drug screens that we do in clinic. You have to send for chromatography. That result is not readily available when you have to make a treatment decision. So I think, at least what we've been doing, and please share with me what you've been doing, we've been using a very individualized approach based on the level of risk for the patient. And we have been doing some benzo tapers while starting methadone and Suboxone or SROM in patients who show a convincing picture of benzodiazepine withdrawal. So Gabapentin usually is something that we think about first, because if that's enough to take the edge off, then great, and it's less risky in terms of overdose. But if not, if despite kind of aggressive up titration of the opioid substitution therapy, the patient is still having uncomfortable symptoms that you suspect fall under the realm of benzo withdrawal, we would do a very low dose diazepam, 5 milligrams a few times a day with really regular follow-up to make sure it's not too much. And again, daily dispense. So having it dispensed at the pharmacy as they're getting their methadone or Suboxone. And also one thing that we've decided as a clinic is we don't increase both doses at the same time. We won't increase the benzo with the opioid. We'll just stagger it and see the patient really frequently. We're lucky in that as of last March, our clinic is now open 5 days a week. So it gives us leeway to do that, which is nice. And also document plus, plus, plus. I think every time you make a clinical decision that carries a fair amount of risk, it's important to document what led you to make the decision that you made. But I think at the end of the day, like, all outcomes here are high risk. So that's what we've been doing. I'm curious to hear from you if you have any additional thoughts. And I wanted to bring this slide back again, just in that context too. It's important to think about, the true signs of benzo withdrawals, the ones that warrant treatment. And it's really, if the patient has ringing in their ears, get that sensory hypersensitivity, look for those in terms of determining whether it is truly a benzo withdrawal from the contaminants of their opioid use. So most of you are probably familiar with the Ashton manual. So Dr. Ashton was a physician who operated a benzodiazepine dependence clinic for many, many years. And she has a website, benzoinfo.com, that has a lot of different sample tapers, which can be very useful if you're curious to go and peruse them. So I just wanted to mention it here. Also, I use a lot of other kind of virtual supports these days, especially in the context of the pandemic and lack of access to therapy. The Mindshift app has a lot of great coping skills, anxiety reduction strategies that I use in conjunction with the benzo taper to help prepare patients for it. Bounce Back and Mind Beacon are free online therapy for that can be used for anxiety or any comorbid mental health disorders that patients who struggle with benzos also have. So I just wanted to mention that. Think kind of broadly when you're supporting these patients. I think that is it. So these are my references, and I just want to thank you for your attention. We still have 87 people here, so not too many people left to start their weekend early. So thank you so much for your attention. I welcome your questions and discussion, and please share your clinical pearls as well. Thank you.
Thanks so much, Josee. That's wow, that was full of all sorts of pearls. There were quite a few questions, and I tried to rate them because some of them were more common. The one that kind of came to the top was a strategy for cross tapering while adding an antidepressant, or at what point might you add an antidepressant when you're launching into a benzodiazepine taper? And one question was whether you would choose to add that SSRI, let's say, at a certain point in the taper or at the beginning. You got the idea?
I get the idea. That is a great question.
Good question.
I find that starting it the earlier the better. It depends why you're starting it, right? So if you suspect that there is an underlying independent anxiety disorder or mood disorder, I think it's worthwhile to get that SSRI on board sooner rather than later. And that can be part of the kind of treatment plan with the patients to say, let's try and get something else on board to help you with these symptoms, so that when the benzo's out of the picture, you're less likely to have a reemergence of your anxiety symptoms or your depressive symptoms. So I might start, let's say, a month in advance and start a medication, make sure they tolerate it well. And I always like to titrate which medication I use based on what the patient shares their symptoms are. If they have an agitated depression or if they're very anxious, I might go for something like typically escitalopram and citalopram are very good, well tolerated, but also I find, mirtazapine for people with insomnia is very helpful. And it depends also what medications patients have been on in the past. So again, collaboratively deciding. But in terms of the time course, I would say sooner rather than later. But it's never too late. If more anxiety emerges than you anticipated, then that's a good time to. And it might be a good time to pause the taper. So stay where you're at. Start the antidepressant medication, wait for that to have some sort of effect, and then you pick up where you left off and you keep going when the patient feels ready.
Great, thanks. The next really common question has been about dosing of gabapentin. How do you launch people into your dosing schedule for gabapentin? How do you titrate? How rapidly?
Yeah, I find for patients who are using a healthy amount of benzodiazepines, there seems to be some cross tolerance there. So I would start, depending on their age as well. It depends depending on other medical comorbidities. But given, let's say it's somebody who's healthy, who doesn't have risk of falls or things like that, I would start, 300 milligrams, see how on day one, and then 300 twice a day, and then 300 three times a day, going up every day or every 2 days as tolerated. And then kind of take it from there. It depends why you're using it. It depends if patients have anxiety symptoms throughout the day, then I would do the typical TID dosing. If patients have mostly insomnia, like for example, the case that I presented, I just used at bedtime and that was sufficient for him. He didn't want to be sedated during the day. So it's very flexible, and that's part of what I like about this medication is you can kind of adjust based on what the patient tells you.
Thanks. Somebody asked, how does methadone affect benzo tapers? Does it complicate the planning and monitoring of a benzo taper?
Absolutely. I think methadone, like any opioid and benzo together, increases the risk of overdose, right? So you have to be mindful of that. But I think if the person is stable on methadone and they're also stable on it depends where the benzo is coming from, right? Like if it's a prescribed benzodiazepine, I think it's pretty straightforward. You just start tapering down. And you already have a lot of structured monitoring in place because they're seen regularly for methadone anyways. For people who are more erratic, who are less reliable in terms of their ability to take their medication safely, I think that patient population is one where sometimes you do have to go the inpatient setting. For example, if you're starting the methadone, they're using a lot of street benzos. I can see that being a too high risk situation to do as an outpatient.
And there's two related questions to that. And one is, well, what would your maximum dose be that you'd be comfortable with for an outpatient taper of diazepam?
Methadone dose?
Oh, no, sorry, not related to methadone. This is related to outpatient tapering. What's the maximum dose you're comfortable with tapering somebody as an outpatient? In terms of diazepam, forget methadone.
Diazepam, okay.
Yeah.
I don't know. It's hard to say. We've done tapers in like the 70s and 80s before. It depends where it's coming from. Most often, people don't come to us with like a prescription of diazepam that high. Usually, it's street purchased benzos. So we figure out where the dose is by waiting until the person is getting comfortable. But I would say at like 70 milligrams, I would start to feel like it's a lot. Although we've done higher than that. I think we've done to like 80 or 90 per day with very close supervision. I'd be curious to know what other people's experience are.
Sorry, I've just check my mic. I think I'll just turn it off. Would people like to, can we unmute people or we can ask questions? I just can't see the participants. Oh, there we are. I'm not sure if people would like to put a hand up and ask some questions. There was a couple of questions related to urine drug screening or toxicology monitoring.
Yeah.
I didn't get that you're doing urine. Like, how would you do that if some of the benzo analogs are not going to be picked up in the urine?
Yeah, so they're not picked up in the two different types of urine testing, right? There's the point of care immunoassays, which typically is what we do in clinic. So we dip these little sticks and it tells us right away. So those the contaminants, the novel benzos don't show up on those tests, unfortunately. And then there's the chromatography. So that's when you send the sample to do GCMS testing, and then the novel benzos do show up on those tests. But the downside is that that test it's expensive, it's not readily available everywhere, and it takes a long time to get the results back. Um, with the latter, you do find out what the contaminants are, but I mean, at the same time, what they use one day might have one thing, what they use another day might have another. I don't know how clinically useful it is to know exactly what's in there. But typically we mostly use, in the context of benzo tapers, we use the urine drug screen to check for other substances. If somebody is on Suboxone and we're doing a benzo taper and we notice fentanyl, then that's more worrisome. And I think that influences how closely we'll follow. And yeah, it just increases the level of risk. I don't know if that answers the question.
There were a lot of questions about street Xanax. And I know this is something that is bothering a lot of us. I have a lot of quite young patients and teenage boys and really young patients accessing very high doses. In fact, often they end up in like a prison setting because they've committed crimes they don't remember and so on. And people have been asking in the question and answer how you gauge what the degree of dependence someone has. Where would you start with someone coming off of street source Xanax?
That's really hard. I have to admit, we don't see a lot of that in our particular RAM clinic. I think, in Toronto, those types of severe presentations tend to go to CAMH, where they do have monitored beds. So I'm not sure. I assume that a similar approach where you titrate up on the diazepam or whatever you're using until the patient is comfortable. But it's hard because you have no idea what they're using, right? It's most likely not even Xanax, but one of those novel agents. So it's very challenging. So I don't know. I don't have an easy answer for that. It's something we're all struggling with.
There was a question very early on about orexin antagonists. Does that ring any bells? It's not familiar to me. Orexin?
Orexin. I haven't heard of it.
No, neither have I.
No,
so I'm not sure.
I have not heard of that. Can the person who asked clarify?
Let's see. Maybe I don't know if they're still here. I don't know. I don't see anybody. Oh, it says Dayvigo, Dayvigo. It's indicated for insomnia. Sometimes used in narcolepsy, not covered by ODB. Well,
and what is the question about it?
The question was
orexin.
Yeah. Does anyone have experience with it? Oh, so with the person who asked the question, do you mean in terms of dependence? Does it seem to be dependency forming? I'm just looking.
Hi, Laurie. Can you hear me?
Yes.
Yes.
Hi, it's Tina. I work on inpatient psychiatry at St. Joe's, and there's a classification of medication that's supposed to reduce the wakeful cycle in the circadian rhythm, and it's orexin antagonists. And I have no experience because the hospital, it's not on the formulary. So I was wondering if anybody's used this in lieu of benzodiazepines for sleep in general, and if they have, what their experience has been with it. It's not supposed to be addictive or because it's on a whole different receptor system altogether. So I was just wondering about that as a treatment alternative instead of using benzodiazepines for sleep, which then become problematic in getting them off over the long term.
When Jennifer just sorry. I was just going to say, Jennifer just commented that it's a zopiclone alternative, supposedly not dependency forming, but also not great for sleep. Some people describe intrusive or bizarre dreams.
Yeah. I will have to read up on that. Thank you for sharing.
Yeah. I was just wondering if anyone had experience with it. That's all.
Yeah.
Somebody asked, did the patient feel better as the dose went down? Your 50-year-old man.
He actually did. It was lovely. Not at first, I'll be honest. At first, there was so much anxiety and he was just grabbing onto the diazepam. But it's been my experience globally that once the person is off a significant amount, they just feel more alive, more connected, more engaged in life. Their mood gets better. This person in particular was an artist and he just started to paint again. It was lovely. Like he started re-engaging in things that he had given up for a long time. I think often because it's so progressive, people don't realize the cognitive impact of long-term benzos. And it's really nice to see people wake up during this process. So yes, he did feel better, which was great to see.
Well, thank you so much. We have about 4 minutes left in the presentation. I just wanted to remind everybody, please don't forget to fill out your evaluation. I will see if I can quickly grab the link, but it's in the little box where the agenda is for this presentation. And if any, oh, there it is. Thank you, Sarah. I don't know how to do it. If anybody maybe wants to jump in with any last questions. And I want to thank Josee for an excellent, clear, really helpful presentation on benzodiazepine dependence and managing it pharmacologically.
Thank you so much. It was a pleasure.
Oh, Sarah says wrong link. That's the right link. There's the link for the evaluation. Thank you. Oh, and also, are you able to make the slides available? I think this might be a general question for the meeting.
I think they are available. I signed a waiver for them to be posted on the website and on YouTube.
It'll be on the Medify website. Yeah. Well, thank you, everybody. We have a couple of minutes, but thank you so much. Really excellent. Really enjoyed this.
Thank you so much.